Thank you everyone for the great presentations. So at this point, I'd like to invite Dr. Burke, Dr. Levy, Chris and Terry to come live to have a Q&A discussion moderated by Joanne Fanning. Joanne is the CIO of our UPMC Global Technology Operations Center and UPMC in Ireland. Thank you.
Here today. It's great to see you all, and I'd like to thank you very much for your informative and engaging presentations. I really think the theme, or what was abundantly clear from your presentations, was the scale and the speed at which the UPMC clinicians adapted to the virtual care environment at such a time of crisis. And I was just wondering also the theme that this technology was here all along. Were you surprised? Were you blown away? Or how did you find that how did you find the response to the technology in such a short period of time? I might put that to Dr. Levy.
Yes, thank you so much. And thanks again for the opportunity to participate in the conference. And I think that that's an important point, that many of the hospitals and health systems that we have been able to help globally did already have a little bit of a footprint in terms of virtual care, so that when the pandemic hit, they were able to rapidly respond to the demands of the pandemic. And I think that the question in many people's minds is, where do we go from here? And I do believe that both from the standpoint of patients, as well as the standpoint of doctors and clinicians globally, that folks have seen a new way of healthcare delivery, in which I believe that it is not at all overly far-reaching to think that in the years ahead, up to about 40% of the care that's currently being rendered in person can be rendered through a virtual platform.
That's very interesting. And Dr. Bart, I noticed as well from your presentation how quickly as well we were able to see the same volume of patients, and that normalized in quite a speedy time frame as well, that patients adapted, especially with some of the examples you gave, to a virtual environment. Do you believe that they've had the same level of care and the same potential quality of outcomes through this virtual media?
Yes, I think that they have. You know, we were very fortunate. We'd had an investment in our technology platforms prior to the pandemic starting. We'd also started working with a number of our clinicians to get them telemedicine capable. And then, of course, working closely with Chris Carmody's team on making sure the infrastructure supported this. But I do believe that by and large, that's one of the things we're trying to learn and study more directly is, you know, the quality of care that's delivered via telemedicine and how that compares with that in the face-to-face environment. I do agree with Dr. Levy's point that a significant proportion or high percentage of care can be done very expeditiously and very competently via telemedicine. There are so many opportunities that are available just in changing how you think about the patient when you're seeing them via telemedicine. We have cardiologists who, you know, one of the things that they always worry about is, does a patient with congestive heart failure, are they developing edema? Well, you can have the patient actually show you that with their phone and their camera that they're using for the visit. So there's a lot of things that are just observational that we're able to do. We do have opportunities where we're using certain tools like digital stethoscopes and others for the delivery of telemedicine. But in many of those instances, you have to have had that pre-established relationship with the patient to be able to make sure that that's available for them, or have the patient come down to a telemedicine consult center, which we have at some of our clinic spaces. So I do think that the opportunity to embed telemedicine, going from a circumstance of forced use created by the pandemic into one where we're trying to align telemedicine and intercalate it with face-to-face visits in appropriate diseases, that's the piece that we need to study now. So, and that's what will give the sustainability of telemedicine in clinical care. Thank you.
So, Terry, I've noticed here that from your presentation, sometimes innovation and progress can be hindered due to the perceived complexity of compliance and regulatory obligations. But your presentation really cut through a lot of that noise, and it shows, I like risk assess and act in the best interest of the patient. And if we take a step back and look at our tools, just ensure our clinicians are licensed to treat in the appropriate jurisdiction, that our patient record is located and secure in the appropriate jurisdiction, and that consent is made simple and clear to the patient, that we really can innovate, bring a lot of these new tools and ideas to an international scale.
Yeah, absolutely. I think that's a great summary. And, with my partners here, colleagues, Dr. Bart and Chris, I mean, when you look at where we were at before COVID, now we've been through it, it's hopefully coming to an end. But to me, my message has been and continues to be, there's no going back. We're going to have telemedicine going forward. The regulators, the government, they're recognizing this. They're always a little slow with things. But when I'm looking and assessing a new telemedicine project at UPMC, the first things, there's two very important things. One is the clinicians. We have such great expertise here. I trust them. And then when you talk about with what Dr. Bart and Chris especially have done with all the technology, these folks know what they're doing. And so it makes my job a lot easier to be able to assess risk and say, yes, we can do this. It's in the best interest of the patient. Do we need a license here? Do we not need a license? But the way this is going to go, I think, forward is COVID-19 disrupted the practice of medicine, but I think in a very, very positive way. And as we move forward, and what Chris said earlier about best practices, it really is an easier sell, I believe, for the governments and the regulators to be able to say, okay, these folks know what they're doing. This is good patient care. It's excellent patient care. And I really feel like moving forward, we're in very good position. And I'm not just referring to UPMC, but, worldwide with what's happened with telemedicine. And so I'm as excited as ever. And I really do believe that the governments and regulators, for lack of a better term, are going to continue to buy into this. There's really no going back. Our patients love it. The clinicians like it. They're used to it. We have the technology. We have the clinical expertise. It makes no sense that someone should have to drive to their physician's office every time for a visit.
Yeah. So I think, with the panel here, what's showing is we have, the technology is there, compliance can be simplified, cyber risk can be managed along the three strands that Chris had set out: people, process, and technology. So really what we need to get together on is how we maintain this momentum for positive change. And, it has to be a movement that continues with the disruption that was caused with COVID. This was the disruptor that got people using the existing tools. So so really, how do we do it? How do we move forward to this whole person care that Dr. Levy speaks of? Because it's in the patient's interest, it's in the public's interest, and it's so proactive.
Yes, thank you. And I think that a very important driver globally for the adoption of virtual care is a growing interest in the disparities in care that exist within healthcare delivery on a global basis. And I do very much think that virtual care is the great equalizer, that one's geographic area does not need to determine one's access to medical care. There are shortages of generalists and specialists around the world. And through virtual care, we can basically do a much better job of matching individual patients with individual providers. We can also, through technology, empower patients so that they can take a more proactive stance through remote patient monitoring and AI. They can take better care of themselves to both prevent chronic diseases from occurring, as well as obviously to help manage those chronic diseases should they occur going forward. But I do believe that focusing in on the disparities in care is going to be a very important driver. And I do have the opportunity to interface regularly with the World Economic Forum. And this is an area of very strong interest within WEF in terms of providing that right balance in terms of regulatory structure, such that patient safety, medical quality is obviously enhanced and preserved. But there's also room for innovation to occur as well.
Oh, absolutely. And Chris, the exponential growth of data over the last decade, we're gone from data centers to data lakes. Are we going to data oceans next? To try and cater for all of this?
We certainly are. And as everyone's sort of alluding to, the expansion of virtual care and again, breaking down those barriers in combination with all the great tools and technologies that are available. And it's not just, medical grade devices. It's things as simple as, Apple iWatch that someone has on their wrist that's collecting some medical data. And luckily for me, I'm just a technologist. I don't have to make any sense of whether it's meaningful or not to provide care to the patient, but I have to make sure that we're able to ingest that data and present it back to the clinicians like Dr. Bart, like Dr. Watson, Dr. Levy to provide that care to determine whether it does make sense. So from a data perspective, the growth will continue. And it's exciting, especially when you overlay technologies like machine learning and artificial intelligence to derive more insights from that data that today we're probably not taking advantage of.
Oh,
yeah,
indeed.
and I would say we need Chris more than ever in this day and age, because all of this data, having the perspective of having taken care of patients on a full-time basis for over 20 years in the Boston area and having a panel of patients of approximately 2,500 patients, the amount of data 2,500 patients can create is simply overwhelming. So I think that given the fact that the primary care doctor of today is already going over so many labs and messages and emails from their patient panels, if they then have an overlay of daily blood pressure and glucometer readings, it's just way too much. So it takes a team. It can't all be directed towards one singular physician. And we need the Chris's of the world to really refine that data, curate that data, and get at that very important differentiation between signal and noise, and really making sure that what reaches the clinician's desk is really those most important values that really are going to be determining the patient's care in their most essential elements.
Yeah, your phrase about data-driven engagement, engaging with the patient, this surround sound to keep them engaged so that they're responding to the broad range of handhelds and treatments or advice. It can just build such a proactive healthcare environment, which I suppose is what we all strive for, really. Well, gentlemen, thanks so much for such engaging conversation and for your presentations earlier. There's quite a few questions coming up here, so perhaps we might collate your answers and come back to the audience offline. But thanks again.
Sure, our pleasure.
Thank
you
you.
so much.
Thank you, Joanne, and everyone for that great discussion. So next, I'd like to introduce our first keynote presentation, which will be given by Deanna Larson. Deanna Larson is the Chief Executive Officer of Avera eCare. This session will be moderated by Dr. Andrew Watson, and Deanna will be giving us insight and an explanation as to the growth of telemedicine, virtual healthcare, and her eCare solutions through the Avera network. So looking forward to the presentation, Deanna. Thank you.